Well, thank you. I'm very happy to be with you today, and I hope the meeting is going successfully for you. I'm Arthur Sagalowsky. I'm a professor of urology at the University of Texas Southwestern Medical School, where I have been for the past 38 years. My main interests in urology are in urologic oncology, primarily in bladder cancer and kidney cancer. I've had a long interest from my bladder cancer work on urinary diversion. The continent urinary diversion has been a major focus of my career. Separate from my ongoing oncology interests, in years past, I had a very large interest as well in kidney transplantation, but my current work is totally centered upon urologic oncology and in bladder cancer and kidney cancer primarily. Bladder cancer in the U.S. as well as around the world remains a very large problem. In men in the U.S., it's about the fourth most common cancer with a similar prevalence as colorectal cancer. In women, it's about the 9th or 10th most common cancer. The overwhelming most common cause is cigarette smoke, and other patients with long lifetime occupational exposures to certain chemical compounds, benzene ring compounds in particular, have been known to be associated with an increased risk of bladder cancer as well. That still leaves, however, some patients who have neither of those two known risk factors and who nonetheless develop bladder cancer, and we don't know why they have it. Bladder cancer, because it's so common, is a major source of morbidity and mortality, and is a very large economic burden in addition to the disease-related morbidity and mortality. So it is a major health problem in the U.S. and throughout the world. Many people have done large volumes translational research, certainly as much or more than our group, but our group for the previous 2 decades was very interested and focused and did many studies resulting in publications on looking at growth pathways that regulate growth and tumor spread. Now, the far more exciting work is centered on genome changes, the gene profiles that we believe and others believe identify tumors at risk to higher risk to progression and metastasis. And so whereas we previously did lots of translational work on cell cycle regulation, we, along with others, would have to agree that the much more exciting work at this time is on identifying the gene phenotype profiles that predict higher risk of invasion, spread, and metastasis. And we think that future treatments will be centered on selected, directed therapy identifying patients in the higher risk groups. And we have done no work yet on the very exciting new immune checkpoint inhibitors, which I think is currently the most exciting area of cancer research, at least from my limited perspective. And I think the immunotherapy that's now possible with the immune checkpoint inhibitors opens a totally new arena that may prove to be an important adjunct to other historically standard treatments of cytotoxic chemotherapy, more recently selective targeted agents. But the new modern immunotherapy I find to be tremendously exciting, and many years ago when I was heavily involved in kidney transplant and unrelated but simultaneous in historical timing, the AIDS epidemic the opposite end of the immunology spectrum, severe immunosuppression, I always believed that as our basic scientists learn to unravel the mechanisms and regulating control of the immune system, the ability to turn on or off cytotoxic killer T cell functions would become a very powerful tool to be combined with other cytotoxic therapy that would result in great benefit for our patients. So I believe we're just at the beginning of that new immunotherapy era, and it's anyone's guess how and which tumors and used in which way will prove most beneficial. Well, for so long, there were no effective therapies for locally advanced and metastatic kidney cancer. We all know that standard cytotoxic chemotherapy was not successful. We all know that long ago there was early success, but in only a very few patients, only a small percentage, responding to rather primitive immunotherapy of interferon, and then in more recent decades, interleukin-2 therapy. But that's really historical therapy for the most part at this time. And now with the molecular targeted agents, of which the tyrosine kinase inhibitors have been used and studied most so far, kidney cancer, advanced kidney cancer, has gone from being an unrelenting disease with early fatal outcome. Now, with the tyrosine kinase inhibitor therapies, kidney cancer has become a chronic disease. Patients are living longer. The progression-free interval has been extended, and quality of life for patients during that time has been improved. Yet the cytokine tyrosine kinase inhibitors have not cured patients, so we need something more beyond that. And just as I said a few moments ago about bladder cancer, we're hopeful, and it will remain to be seen if the modern immune checkpoint inhibitor therapies coupled with other therapies might also prove tremendously active in kidney cancer. As various drug therapies extend the life of the patients, and as anesthetic technique and surgical technique become safer, as they have made great strides in recent decades, the role and the benefit of subjecting patients to cytoreductive nephrectomy, I believe, will continue to be important, but it remains to be proved. It could also turn out that the various evolving and hopefully improving drug therapies, whether it's immune checkpoint inhibitors or others, those have to be compared to the therapy alone, with or without cytoreductive nephrectomy. And as was pointed out by the other speakers in that session yesterday, we'll have to learn, does it make a difference? Is it more beneficial in one sequence or the other way around? So there's lots yet to be studied, but I'm optimistic that there's every reason to be hopeful that we will learn how to manage the patients more safely, and give them better quality of life, and hopefully maybe even cure an increasing fraction of patients with metastatic disease. Well, I'm happy to do so. I don't know if there's a single turning point. I was always interested in surgery in virtually all of its forms. And the two surgeries that intrigued and interested me the most were urology and neurological surgery. I had the good fortune of training at Indiana University at a time that John Donahue, the former chairman in urology, and Larry Einhorn, medical oncologist, together were making wonderful advances in the treatment of testis cancer, a disease that previously had a very high fatality rate. So I grew up as a medical student and resident to be in a location where urology looked tremendously exciting and coming up with great advances in improving the survival rate for patients with testis cancer. And that caught my attention and my interest. And in addition, I should add, my older brother also became a urologist, and that undoubtedly was an influence on me as well. I always wanted to be, and I always tell our students, I was a doctor first, and then I chose to become a surgeon, and then after being a surgeon, I chose to be a urological surgeon. But I never want to forget, and I never want the students to forget, they should first wish to be a doctor. And that opens a whole world of chances and opportunities within the framework. They should never regard themselves just as a neuro specialist or a surgical technician. I tell our residents and our students they must not simply become a proceduralist. They must remain at heart a doctor. And if they happen to be a surgeon, fine. And if they choose to be a urological surgeon, that's fine as well. But whatever field they go into, their starting point should be that they genuinely and truly wish to be a doctor, which is a wonderful thing and a wonderful lifetime opportunity.
Yes, thank you. Thank you for this interview.
Thank you.